Wagwan, everybody. Welcome to the Dis-Affamie History Podcast, where we'll be speaking about history and as well family history and how history relates in terms of Caribbean people for the present as well as in the past, and how in the past what that does and brings forth for what we are going through at present and what we can learn from our history, from our family, and take that moving forward. So I do hope you enjoy the podcast, and if you like it, please ensure to subscribe, like, and review. Thank you.
In this episode, I would like to Katrina for coming on to the podcast and to be able to speak about pernicious anemia. It's one of those conditions that are not well known, but does have a severe impact on the lives of the people that do have it. So first of all, if we can get you just to introduce yourself and tell the folks, the audience, about your organization as well as yourself.
Okay. Well, firstly, thank you for inviting me, and it's a pleasure to speak to you in more detail about this. My name is Katrina Burchell. I'm the Chief Executive Officer of the Pernicious Anemia Society, which is a charity based in the UK but has international membership. And we represent the interests of people who have been diagnosed or suspect they have pernicious anemia. We're both a patient advocacy group and a patient support group. So this is an interesting time as well. B12 deficiency is a significant symptom of pernicious anemia, and something that a lot of people are interested in at the moment. Seems to be a growing problem. So this is a timely discussion with you about this condition.
Yes, thank you so much for that. And so we'll start with just, what the definition of what pernicious anemia is. You kind of mentioned it a bit there, but if you could just define it for the audience.
Yeah, sure. So pernicious anemia is an autoimmune condition, which and autoimmune conditions are basically when the body attacks itself. In normal, let's say normal healthy people, the stomach has these parietal cells and intrinsic factor which take B12 out of the food that you eat and put it into the blood and eventually your cells, and that's how it works in the sort of normal course of events. People who have pernicious anemia, they either don't have parietal cells or they have antibodies which attack those parietal cells, and that means that they can't absorb B12 from food. People with pernicious anemia also often have atrophic gastritis, or they may have low stomach acid, which also affects your ability to absorb not only B12 but other nutrients. And as you get older, the volume of stomach acid reduces naturally, and so obviously people sometimes pernicious anemia doesn't present itself till later on in life, although people of all ages can get it. Like other people with pernicious anemia often have more than one autoimmune disease as well. So if you have an autoimmune disease, you are prone to having others. So people who have thyroid, vitiligo, things like that will possibly also have pernicious anemia.
Oh, thank you for that. Sorry, go ahead.
Oh, I was just going to say that the interesting thing, or thing that I find really interesting, is that pernicious anemia is a bit of a misnomer for the condition, because it was called pernicious because 120 years ago when it was discovered, pernicious means fatal and people died of it. There was no cure, people died. That's not the case today, because most people present with symptoms before they are actually anemic. So actually the word anemia is a bit of a red herring. It's actually a problem in the stomach, which then affects, obviously, ultimately affects your blood and could make you anemic. But if you've got to the stage where you're showing symptoms of megaloblastic anemia, it's gone too far in a way, and certainly people shouldn't be hopefully left until that stage before they're diagnosed. But the problem is that when people present with symptoms with pernicious anemia, their symptoms can be symptoms of anemia. So they can be breathless, they can be the pale, all the sort of classic symptoms of anemia, which might also be like the same symptoms for iron deficiency anemia. Or they might present with gastric problems, or bowel problems or gastric problems, and they might present with those type of issues. but the most common issues that people present with are actually neurological or neuropsychiatric. So these are the ones where people have pins and needles, an unsteady gait, they have perhaps vision issues. The one that most commonly people describe is brain fog or concentration issues, or problems with finding words, concentrating, things that obviously that make them concerned that, you know, what is wrong with them, because it often happens, these things often creep up insidiously on people and they don't realize that these are all symptoms of a B12 deficiency caused by pernicious anemia.
No, oh, definitely, for sure. And the fact that you mentioned that, you know, pernicious anemia being fatal, because I know for myself in my family history, you know, my great grandfather, he died of the actual condition back in 1912, I think it was, before there was, you know, the treatment for it, and it kind of leads into, you know, who it would be more prone to pernicious anemia, and of course, is there a hereditary connection to that as well?
Yeah, so this is a really interesting question, and something that we, and I know you're particularly interested because you have a family history, as do I. I have people in my family with pernicious anemia and related conditions, autoimmune conditions. So first of all, I think it's really interesting to point out that, like many autoimmune conditions, pernicious anemia is more common in women than men. It does exist in men, but and you know, obviously, but generally it presents more in women, about an 80 to 20 ratio. There is a myth, or there was a myth, that it was primarily people of North European descent that were prone to this, but there's insufficient research to really say that that is the case. And actually there's research that suggests that isn't true, because for example, there's quite high rates of the other connected autoimmune diseases in Asian and Afro-Caribbean backgrounds. And so you have, you know, Hashimoto's, Graves', all these other autoimmune conditions which commonly present with pernicious anemia. So, and so there is research to be done, but generally it can affect anyone of any age. It's slightly more common in older people because it does take a while sometimes to present. But generally, you know, it can be people of any age. If you look at B12 deficiency generally, and I think that's worth mentioning too, because later on we'll talk about probably the difficulty in diagnosing pernicious anemia because of the lack of, you know, accurate tests. So people who might be diagnosed with a B12 deficiency without having a diagnosis of pernicious anemia, there's a very high proportion in the Caribbean background and in East Asian women predominantly. But with pernicious anemia specifically, I thought it was quite interesting. I just need to look at my notes, because there was a study in 1999 in the USA which said that, specifically said that pernicious anemia is as common in Black and Asian Indians as well as white. So I think that's quite an interesting point, because there is this myth, and I think especially when you present to a GP or to a primary care provider, that there will be an assumption that it's an elderly white female disease, and that certainly isn't the case. You mentioned also about it being whether it's a hereditary condition, and we tend not to use the word hereditary because that sort of implies a genetic link, and that's something that needs to be researched, and we don't know the answer to that. But so we tend to talk about familial clustering, and that is definitely the case. It's the case with autoimmune disease, but it is specifically the case with pernicious anemia. Again, interestingly, lots of research that needs to be done in that area, but what we already know is that it's very common amongst siblings. It's very common amongst generations as well, but sometimes skips a generation. So you may find grandfather and grandchild, or grandmother and grandchild, but possibly not the person. And you're nodding and smiling because presumably that's experience that you have had.
Oh yes, definitely, because it's it's the grandchildren of this great grandfather that all, well, the majority of them have had it. And as you said, when you mentioned about clusters, it's exactly so, because when you map it out on the family tree, you can kind of see where it's actually occurring and which generation where it's at as well.
Yeah, and I think if research is sort of expanded to the wider autoimmune area, you'll find that there will be other related conditions. So as I mentioned, vitiligo, thyroid issues, also celiac disease, which is quite common. So there is a Crohn's, all these type of things that have a similar type of background and presentation. Somebody in your wider family may not have pernicious anemia, but they may well have one of those conditions as well. Even asthma, as well, allergies, very high histamine, people with pernicious anemia. So it's unfortunately, it's like, you've fallen into this silo of autoimmune diseases, and you're going to get one or some of them.
Yeah, very true. And now, with you kind of mentioned a couple of things, but with pernicious anemia, the impact on the body and its ability to absorb B12. Can you just go just a little bit into that for the listeners?
Yep, sure. So I should say I'm not a medic or scientist, and that's not my background, but I am a patient, and obviously I've had the pleasure of working with a lot of knowledgeable people about pernicious anemia, and researchers and doctors. So everything I've learned is through that way, and so what some of the terms I'll use are for sort of layman's terms rather than the scientific ones. But essentially, B12 is only found in animal products. It's taken up by by animals who eat grass and from the soil. Of course, it can also be manufactured artificially, but it's absorbed in your body in different stages of digestion. So your saliva will take some B12 out, your stomach acid, as I mentioned, and your intrinsic factor will take some out, and then there's a very, very small amount that will come out when you've digested your food and it's on its way out through the ileum. So there can be various stages of the disease, and some people will be absorbing some and some will absorb none. And I think that's, again, something that needs further research. We don't know why that is the case for some people and not for others. What we do know, though, is B12 is what's called an essential vitamin. Without it, you will die. I mean, that there is no, every cell in your body, your whole DNA is based on having vitamin B12. So you need to get it. It needs to be replaced. With people with pernicious anemia, it needs to be replaced artificially, and that's normally done by an injection. What's the impact on the body? Well, what normally happens and what we see presented all the time is that it's a disease that creeps up on you. And it can happen very slowly. It can, certain life events can deplete what little B12 you may have even more. So for women, things like pregnancy, menopause, but things like stress, an operation, all of these things can make you drop even further. But normally people will come first presenting with symptoms that are the ones that I described before. So maybe being breathless, maybe being profoundly fatigued. So we're not talking tired, we're not talking people who've done a little bit too much, but really noticing that they're not able to do what they were doing before. In my case, it was, I used to run a lot, and I wasn't able to do that. I wasn't even able to walk my dog sort of 50 yards up the road. So I knew there was something significantly wrong. But also other things like could be fertility problems, menstrual problems, all of these issues that will start presenting themselves. And if you go to your listeners, go to our website, they will see there's a sort of checklist, and it's a huge number of symptoms. And what is important is that not everybody will present with all the same symptoms or even the same combination. because they will all come at slightly different times. So, and what is worth also mentioning is that those symptoms often overlap with other problems. So, for example, iron deficiency presents with some symptoms the same. Other types of anemia may also, lupus as well, conditions like that. And also things like multiple sclerosis, Parkinson's, a lot of the pins and needles, the shaking, the tremors, the visual disturbance, these type of symptoms do overlap, and that's why it is quite a challenge for doctors to diagnose. They won't necessarily look at pernicious anemia or B12 deficiency because that isn't necessarily something that will be first in their mind. But if you have a history of it in your family, then it's something you need to share with your GP, because that will be a flag then for the GP to do a test.
Oh yeah, no, for sure. And because I know that you mentioned there's a lot of different symptoms. Not only that, it mimics a lot, so it makes it very challenging in terms of being able to diagnose it. Would you know, could you just indicate, I guess, just some of the top ones that would definitely be part of that the signs that the healthcare professional can be vigilant for?
Yeah, so I think my experience is that most people will first complain of neurological symptoms. So they will talk about pins and needles. They may talk about struggling to breathe. They may have noticed twitching, maybe in their in their eye or something. They may feel like they're having palpitations. And the other key symptoms, which often worry patients a lot and put them off actually having this conversation, is the confusion and the brain fog, the forgetting the words, the inability to listen and concentrate for a long time. They may develop tinnitus, which is very annoying and frustrating. They may be concerned that they have dementia, or there's a lot of panic about that. And there's also, I think, because of the prevalence in women, this sort of fear of women that some of these symptoms they describe are often dismissed by the medical profession, particularly if they are a menopausal age, for example, or many of our members report that they've been, to use a sort of common modern word, gaslit by the medical profession, told you're doing too much, you've got young children, you're working, you go to the gym, and then or you're overweight or you're underweight or whatever the thing is, and they'll be dismissed and probably go away for some time before coming back and saying, no, I actually still do have these symptoms. And of course, one of the biggest challenges is that generally you feel so ill that it's quite difficult to explain, but it's a very different way of explaining to your doctor. I always describe it, if you've broken your leg, it's fairly obvious to everyone. Yes. What's happened, and there's an obvious way of looking for it and treating it. With pernicious anemia, it's much more of a challenge to, firstly, for the doctor to start looking if that's the cause of your symptoms, and secondly, even when they suspect that, the current tests for pernicious anemia are inaccurate and unreliable.
No, for sure. And I guess this is where either you're the person that is suffering from the condition or the person supporting them really has to advocate for their health, to say, something else needs to be looked at. Because I know with not only going just to the family doctor or the general GP, but now you're going to, let's say, a specialist, and sometimes their screening questions may include, what is the family history of ABCD? They give you a whole laundry list, and you take it from there. Because I know for the person that I support, that was part of the neurology type of questions. And I thought, oh my goodness, and it made for a different conversation having with the neurologist. And that too, I guess is part of the, you have to own your healthcare, so to speak, unfortunately, nowadays, because as you mentioned, people will be gaslit to say, now they're there, you don't have to worry, it's probably something you'll get over with in a couple of months, come back to me later. And by that time,
Or they might suggest, for example, a lot of our members report that, the doctor will say, oh, go away and take an over-the-counter vitamin or something. But of course, if you have pernicious anemia, that's not going to help you. And of course, that might then delay diagnosis because you go away, you try and actually don't get better. I think also, I think what's important for people to know is to know their family history, definitely to ask around in your family. If you already have an autoimmune disease or there is a history of autoimmune diseases, then that's definitely something you should share with your GP as a flag. And I think one of the things that is really helpful is to look at websites like ours and look at the checklist and actually try to find the words that describe what you are, that a doctor will react to. Because if you just say that you're tired, I think tired all the time, and it's often used as a sort of shorthand for doctors. Everyone's tired. That's how they'll look. But if you use the word fatigue, and if you talk about your inability to do what you could do maybe 3 months ago or 6 months ago, like the distance that you could walk, the number of hours that you stay awake in a day,
exactly.
All of these things, I think that this will help you. And I know it's difficult when a patient is ill, and if you can take somebody with you, obviously, to those initial discussions, that's really helpful too. The nominal aphasia, forgetting words and feeling confused, is a very, very common symptom. But of course, it is a symptom of other things as well. And we always say to people, new people who come to us and who are worried about it, we say you should have the other tests too. It's important that you check those things out. So, for example, in my case, one of my symptoms that presented was I had what I came to understand were these hallucinatory smells. So I smelt smoke when it wasn't there. But for doctors, that's actually a trigger for brain tumors. So they want to do an MRI scan to clear that out. But then actually, when I read a bit more, it isn't uncommon for people to have either visual or auditory or sensory hallucinations when they have a B12 deficiency. So that sort of explained why I had that. But obviously it was right that the doctor checked for the other things as well.
No, definitely. Because you said this is it mimics a lot of different things. So it's going to take a lot longer to kind of diagnose and to get to the actual source of what the condition is, but it's good to know. And I'll put the link for that from your website in the show notes, so people can use that as a template for when they are going and having that discussion with their family doctor or GP, or even the specialist at that matter, because again, using that language will help significantly. And I know that you mentioned in terms of with pernicious anemia, in terms of the treatment, it has to be an injection of B12. How exactly they can't take, let's say, a tablet for treating this vitamin B12 deficiency?
Yeah, so again, this is an area that needs significant research, because one of the things we don't really understand yet is why some people need more replacement B12 therapy than others, and why some people. And so at the moment, for example, some countries will administer hydroxycobalamin B12, and some countries use cyanocobalamin. So that's two different forms of B12. In some countries, in Scandinavia, for example, they do use high dose oral tablets. And so for some people, if you have some parietal cells and some stomach acid, you may be able to absorb enough through your stomach. And we do have members who do use high dose B12 oral supplementation, but it may depend on which stage they are in of the condition. However, the vast majority of people will need an injection directly into their blood, because there is no point doing it through your digestive system, no point storing it in your liver, because it has to come back through your stomach, and it will not get back into your blood cells. It will not be active, and you won't get better. The challenge is also really understanding which people need what frequency of injections, because that varies from country to country, what the advice is, and it varies even within a country and the doctor as to what they will give. And a lot of people through their own journey find that they don't get enough B12, and they're on a roller coaster of living, say a normal life for a while, and then tailing off. The return of symptoms come, and we get a lot of members, particularly from North America, the US and Canada, and from the UK, who are very, very frustrated that they live in this feast and famine world of getting a B12 injection where you get a shot. If you can absorb B12 through digestion, you eat a little bit every day, but this would be a better solution for people with pernicious anemia, is to give them a little every day and not a massive dose every 8 or 12 weeks, because the logic doesn't make sense. But unfortunately, that's how it is at the moment. We, as the Pernicious Anemia Society, we have a lot of research questions that came out of a priority setting partnership that we did with the James Lind Alliance, which came up with 10 top questions for research to answer. And again, if you look on our website, you'll see what they are, and they're really fascinating. One of those is, why do some people need it more often than others? Why do some people need it every day? Some people can go 12 weeks without any problem. Most people are somewhere in the middle there. Why do some symptoms return? Why do some symptoms never go away? So for some people, most of their symptoms will be resolved once they're getting adequate treatment. But for some, they will be left with something. They will be left, again, in my case, I still have pins and needles in my fingers and feet, which never goes away. So no matter, and that's something because I was late diagnosed. Unfortunately, that is quite common. Some people report that all of their symptoms have gone, and we do have members who have run marathons and who have, after diagnosis. So for some people, a full normal life is fully possible. And of course, life expectancy ultimately isn't changed, but quality of life for many people is. And unfortunately, many of our members report having lost jobs or had to give up jobs, and perhaps more sadly, have lost relationships, because people really do not understand the condition. Family members can be very uncaring and unforgiving, because you never get better, and sometimes you need to sleep a lot, but also friends and work colleagues can be very less than understanding, because it's an invisible illness, and not very often heard about. So one of the things that was quite a brave step, and I know a lot of people find it quite difficult, but it actually made a big difference in my life when I started admitting I had pernicious anemia. Before, I used to just try and cope and pretend that there was nothing wrong with me, but now I'm much more open about it, both at work and in with my friends. And I and actually can sometimes laugh and about when I forget a word and will make up a word for something, and people sort of acknowledge, and they'll sort of say, oh yeah, that's your pernicious anemia talking.
No, for sure, because it can be isolating when no one can be able to relate or to how to not necessarily deal with you, but be able to kind of take you and know what it means and understand. And it's the fear of the unknown, right? So what I don't know, I'm going to be afraid of, and I'll step back, whether that's family, whether that's friends. And it's great that you were able to just say, I'm just going to say, this is what it is. And people have been receptive to take that, because that support system means a lot. It carries a lot. And as you said, it's the quality of life. And, individuals may suffer because people don't quite understand. And again, it's the fear of the unknown. And it's one of those conditions that, will unfortunately have people not really be there for them, because it is, why is this person sleeping a lot? I thought we got to the issue. They have to do, take their injections and that's it. But as you said, it continues. It may not fully recover from those initial conditions. And I guess it just leads into the whole, the long-term complications associated with an untreated or inadequately manage pernicious anemia, because
Yeah,
I'm
we
sure
had an interesting person in a support group that we ran earlier this week, actually, who said that she had been treated with regular B12 injections for some time and was coping very well and everything was fine. She'd gone back to work. And then she said, oh, but really in the last sort of 8 months, I've been really struggling and all my symptoms come back and I don't understand why. And so we said, has anything changed? And she said, oh, not really. And then she said, well, actually, I've been diagnosed as diabetic. And we're like, well, there you go. Your body has changed, and it's you need to go back to the doctor and say, my symptoms have returned. You probably need more B12 to help you cope with this. Also, we know, and all the healthcare professionals should know as well, that if you're diabetic and you're on metformin, metformin is a drug which depletes B12. So you're getting a double whammy if you have pernicious anemia and you're taking metformin, because you have a very limited chance of having any active B12 in your system. And there are other drugs that the doctor can offer you instead of metformin. So it's very important that you have that conversation. Equally, we have people who talk about so nitrous oxide is another, Entonox laughing gas is another drug that will deplete B12. And so you should definitely make sure that you tell your dentist, your doctor, if you're having surgery or any investigatory procedures. And definitely, if you have family members who are at risk of pernicious anemia, they shouldn't be using nitrous oxide recreationally, because it is very dangerous for people who have a B12 deficiency.
No, for sure. And it's just, I guess it just, again, is one part of what your group offers in terms of the support. And maybe we might just get to that right now, because it seems like that is very important for people to have that support for their, mental health, and just to know that they're not alone in this, right? Because it's not well known, this type of condition. And when something is not well known, people would feel, I guess I said, isolated, and kind of ask those questions, well, why me, type of thing.
Yeah, you're right. And I think certainly my own personal journey was like that. So I had the most terrible brain fog. I was really struggling to, function at any level, profoundly tired, and all these other symptoms. I thought I was going crazy. In extreme cases, people are delusional, have psychiatric issues. Anxiety is a huge problem. So something that I had never experienced before. I had many panic attacks. And I thought it was only me. When my GP said, I think you have pernicious anemia, and I said, oh, that's interesting, I think my grandmother had that. And then this sort of little light bulb went on, and we're both like, yes, this is what it is. Obviously, I went to the internet like other people do and found that. And then I read the book that had been written by our founder, Martin Hooper. And literally cried when I found that there were other people who had the same condition. I was like, there are other people out there. And we hear that so many times, when people come to our support groups, when people ring up our help desk, when people send emails to our helpline. And then when we go back and we say, oh, yes, that's obvious. Oh, yes, everyone has that, or everyone explains about that. You can visibly see them start to sort of believe that there is a future for them, and that that they can, and also the way that currently the medical profession, and this is true in all countries, unfortunately, once that you've been diagnosed and they start you on the treatment, they assume you are going to get better. But for many people, it doesn't happen quickly. For some people, it can take a year or more before they start feeling better, and some people years, before all their symptoms have resolved. So, and nobody really is told to expect that. Also, doctors don't tell you all the other things that you need to look at as well, which is, obviously to keep your iron levels checked, your folate levels checked, because you need all of these ingredients to make healthy blood cells. And what you mustn't do, obviously, is get to the point where you're deficient in other things too. Because if you start increasing your B12 intake, then your body is going to use up more of all these other things to make healthy blood cells. So but the key thing, as you said, is that people want to feel that they're part of a tribe, or that that other people have suffered the same as them, and also the experience that they get. We talked about women, for example, feeling gaslit. We have a number of male members who will say to us, we really struggle because my family don't understand, and I feel they find it very difficult to explain and talk. Women are used to talking to each other in a way, and I think men sometimes struggle even more with that. So there's a lot of challenges. I think it's also worth mentioning that there's a lot more information generally, not just on our website, but is a lot more information generally available on the internet and social media groups. And some of it is accurate and helpful, but some of it is also very misleading. And so, our position is really people need to go to what is a trusted site and try to avoid, to some extent, some of the more extreme views and the sort of crazies who are recommending things. I mean, we've had people on social media groups saying, I went to a functional nutritionist and they cured me of my pernicious anemia. Well, you can't be cured of pernicious anemia. It's a lifelong condition. And that's just misleading if people think they're going to get rid of it.
No, for sure. And I know that your group, because when I was researching, you're the only group that I was able to find in the world, but you do have chapters elsewhere, right? Is that correct? And I can put that in the show notes as well. But if you can speak to the chapters.
We're building that up. I mean, we are, you're right, the only organisation specifically looking at pernicious anemia than a non-profit. I mean, there are other organisations, good ones, that look at B12 deficiency for other causes, because B12 deficiency can be caused by dietary deficiency, particularly if you're vegan or vegetarian. There are people who have had stomach surgery, for example, celiacs. There's also people who have atrophic gastritis. There's a very good US support group for that. But we, as the Pernicious Anemia Society, we have support groups both online and that meet in person, and we're building those up in different places. So they're in the UK, we have one in the US, which is an online one, and is in North America. So obviously for Canada too, would be welcome to join that. The challenge, and I think this is true for all small charities, is getting volunteers to do this. And also for us, particularly, getting volunteers who have pernicious anemia to commit to doing these things, because, as I mentioned before, a lot of people are still on this roller coaster journey to feeling well. And when they do feel well, naturally, they want to go back and first re-establish their life with work, with family, with relationships and the like. And sometimes they then come back and say, yes, we want to help the charity, which is what happened with me. But it is a challenge at the moment, getting people. And I think also COVID has changed the world such a lot in terms of how people want to interact with other people. So we've seen a more of a move to people wanting online help, whether that's, and I don't mean online like this, but I mean, could even just be wanting an email or a WhatsApp message answer rather than a face-to-face meeting. And actually, even doctors' appointments have become that way. I don't know how it is for you, but here in the UK, you very rarely see a face-to-face appointment with a doctor now.
No, definitely here in Canada, it's definitely the option. You do have the online option for sure, and it is definitely available and continually to grow, right? And as you said, as healthcare changes, that's the other thing, for that. So, it's just a lot of different things with a condition like this, and to kind of look at it in a very broad spectrum as opposed to being very narrow. And, we can go, I guess, to the research efforts, because I know your group is big on advocacy for this. So if you can just speak a little bit to, I guess, the research efforts on pernicious anemia and its treatments.
Yes. So we, again, that probably differentiates our organisation from others in that we commission and fund research specifically into pernicious anemia and B12. We are a member of an organisation called Club 12, which is a group of over 160 researchers, medics across the world. And this is a fairly new initiative where they come and they share research and they work on projects, and they have speakers that come and talk to them. And what I recently went to a conference. I was a speaker at a conference in Rotterdam with the B12 Institute, and through those 2 days of lectures about B12, what was very noticeable to me was how much the research community did already know about B12 and how it works in your body. But comparing that with what the medical profession knows, the medical and healthcare profession know a very, very small amount of that research, and actually often are misinformed about what the research currently says. And then there is this huge other area, the other side, of questions that still need to be answered. And we've talked about some of those. So familial links, why some people need more than others. Why are the tests so inaccurate? So, for example, the test for intrinsic factor is only accurate in around 40 to 50% of cases. So if you get a positive diagnosis for pernicious anemia from that, then you have pernicious anemia. But if you get a negative result, it doesn't mean you don't have pernicious anemia. So this, and also obviously the B12 serum test, which is what the primary care provider starts with, that is also extremely inaccurate and can be affected by fortified foods. For example, all cereals are fortified with B12, energy drinks. So if you are having those, and of course the irony is, if you are profoundly tired and fatigued, you are probably looking for ways to boost your energy. Exactly. And you've probably taken on a significant amount of B12, which will skew the results of your blood tests. And so that's something, again, that you should share with your doctor, because it's very clear. We know that the results, and also the results can vary. We've got some research, and we've actually got a blog post coming up on our website in a couple of months' time, talking about how even the B12 serum blood test can vary from day to day. So we have all of these research questions that we want to ask. We've got 2 research projects going on at the moment. One, a very interesting one, looking at people who are on injections every 4 weeks, who are reporting daily on when their symptoms return. So that will be very interesting. Another research project that we're very interested to see the outcome of is a survey that went out to healthcare professionals, asking what they did actually know about pernicious anemia. And we're expecting that to be really quite telling, I think, in that how poor generally the knowledge is. And another research, which we're just starting actually in the next month or so with the University of Norwich in the UK. So we have a lot of things. We do a lot of surveys. And I think that's what's different about our membership, is that we use our members as the cohort for those research groups. And they are reliable people. They have lived with pernicious anemia, or they're newly diagnosed with pernicious anemia. They're very articulate about their conditions. And we are very well respected by research organisations to provide those people to give those answers. And we want to do more of that. I mean, that's definitely my passion. I want to answer more questions, and that can only be done by research. And the problem is that every research paper that's published, then it answers one question, but it raises another 20 that we then want to answer. But there is a lot of good stuff out there as well. There is stuff that's already been done, and working with Club 12, trying to collate all that information in a place where researchers can have access to it and not reinvent the wheel. That's going to be a very valuable activity too.
No, absolutely, because just to get all that information from that pool that you have, that group of individuals, will forever, make it a lot more better and much easier for others coming along with this, because as you said, this is not very well known. People suffer kind of in silence. They're looking out. This is the only group, in the world pretty much. Yes, you have chapters, but it's really hard to find. And that's the the thing, that at least you have that support group you have the research arm of your group, and I guess that speaks to, again, putting out that information for the early detection and intervention, and of course managing, because as you said, it may take years for someone to overcome their symptoms still. And going back, I guess, to it, because I know you mentioned this before in the discussion, but again, with individuals and healthcare professionals, how to really promote, I guess, a timely diagnosis, because I think, I guess that would be the conversations that you're having, using what you had as, I guess, the checklist. Is there, anything else that you can think of that would really assist us?
Yeah, so I mean, it's really interesting that you said that, because the Pernicious Anemia Society did a survey a few years back, and one of the sad results that came out of that was that 19% of respondents said it took them 5 years or more to be diagnosed. And even more shockingly, 14% of respondents said it took more than 10 years to be diagnosed. So that's backwards and forwards to the doctor saying, I don't feel well, there's something wrong with me. And if we start looking at what the cost of that was in terms of all the appointments they had, all the tests they had, all the routes they went down, because they probably were tested for lots and lots of other conditions. They probably had MRIs and all sorts of things. There probably was a number of visits to A&E, to emergency care. So all of those things, when a doctor, maybe should have added B12 to a fairly early test. And I think the only way to do that is for organisations like ours to educate the healthcare profession to think about B12. And I think there's a bit of resistance in the healthcare profession at the moment. They tend to see it as a trend, as there's this sort of, if you like, a bit of a way that things have been managed negatively, in the sense that people who use B12 sometimes for lifestyle. You hear celebrities injecting B12 because they want to feel better after a hangover or whatever. And so doctors tend to think, oh, you're sort of addicted to B12 and you need it. Or there's obviously also a growing interest in plant-based diets, which do result in people being deficient in B12 if they're not supplementing properly or sufficiently. So I think doctors they hear all this noise around B12, and somehow the issue with pernicious anemia and the autoimmune disease gets sort of buried under that, and they start sort of dismissing. And again, I come back to the point that it is largely women who are coming, and there is research that shows that women are more generally dismissed or take longer to diagnose than men. I mean, one of the things that would be great, I think, for the patient is to go armed with as much information as they can, and that's something that we are trying to do. So we have a series of help sheets. If you're a member, they're in our members section, and these are things like one sheet of paper which will help you explain to the doctor. So, for example, we have a sheet about retesting, because once you're on B12 injections, there's no point having a B12 test, because your B12 will be sky high because it's been injected into your blood. But doctors are trained to always do a blood test as a sort of marker of where you are or where they're starting from. And then quite often what happens is they will say, wow, your B12 is over 2000, or and that's very high, and so you've got to stop, because erroneously they think B12 is toxic, which it isn't. And so we have got help sheets which explain that, and which provide links to research and to documents, so the doctor you can leave that sheet with the doctor. Now, of course, that really depends on what the doctor is like. 50% of doctors are interested and will help, and they'll want to know and go and look things up. And unfortunately, there is a percentage of doctors who have a more arrogant, don't tell me, But the best person, my own personal GP, who is now retired, is a great person, and he always says there's nobody better to tell you about a condition than the person who has it. So people should go with some confidence that, you know, if you live with pernicious anemia and you have pernicious anemia, you should be able to, you should know more about it than your GP, definitely.
No, I couldn't agree more. And you're right. It's just to arm yourself with as much information and to, you know, I know it's easier said than done when I say this, but it's just to own it, to say, this is what is happening to my body. This is what I'm living with. Please listen, you know, and, you know, these are all the symptoms. And as you said, to have these sheets and to go into that, because I noticed, as I said, I know when I did this whole research on, you know, genealogy in my family tree, came across this condition, going to, you know, specialists, it was a completely different conversation from that point onwards, because then they look at you kind of differently, knowing that you're armed with a certain level of information.
Yeah, and I think if you've got that information from a reputable source, like a charity like ours, then that is something that a doctor should, as a professional, take respect from. Because, for example, all our help sheets are reviewed by medical professionals, GPs. So it's not that we are just making up based on what the patient said. You know, we are making sure that what we're saying is accurate. But what doctors, and I think to some extent I have some sympathy for that, you know, that it must be very frustrating if you've spent 7 years qualifying as a doctor and then somebody comes in and says, I read on Google this and this is what I think I've got. It must be frustrating, but I think that's not the conversation that we're talking about. We're talking about just going and trying to explain to the doctor, these are your symptoms, this is how they've occurred, it's not how you were before. I talked earlier about anxiety, you know, that was something that I didn't have before, but it came and I really didn't know how to cope with it. And it became a spiral because I actually did have anemia, megaloblastic anemia, and so I couldn't breathe, and so my anxiety turned into panic attacks, which I literally couldn't breathe. So it was a very physical reaction as well as a psychological reaction, and it was very out of character. My whole personality had changed, and I think, you know, when I started explaining that to the doctor, I think that's when the sort of light bulbs went on, which was I was aware that the change was significant. And I think that's something that it's very difficult to have that conversation when you're not well. And that's again why I would say, if you can have somebody with you in those early conversations who can try to take notes, who can sort of say to the doctor, you know, yes, I've noticed these changes as well. That could really help. I mean, again, early on in my diagnosis, because it did take me many years before I was diagnosed, I kept being accused of not eating a healthy diet, which was ironic because I did have a very healthy diet. And I was, you know, trying to add more and more B12 and folic acid into my diet, and iron, because I was also deficient in iron. And a turning point was actually when my husband came to an appointment and said, but she does eat all those things, you know. And again, I think if you can, obviously everybody's slightly different, but maybe keeping a chart for yourself of your symptoms and how, you know, what if something makes things worse. I had a conversation a little while ago with a friend of mine who also has a B12 deficiency problem, probably has pernicious anemia too, although hasn't been diagnosed, that she was struggling when we had the very hot weather and the heat wave, and I said to her, you probably need more B12. B12 is a water soluble vitamin. You've probably sweated out more than you would normally, and you probably need another injection. She got another injection. She's like, I feel better. Well, yeah, stop. You know, you don't deny yourself. You know your body, and I think that's when you need to say to the doctor, you know, my circumstances have changed. I feel different. My symptoms have returned. This additional symptom has come. I would just caution there that obviously some things are flags for other things. So, you know, and I've been guilty of that myself, where I've thought, you know, it's pernicious anemia, and it turns out that I've had a cold or you know, whatever, a headache, which, you know, was something not related at all. So
No, I mean, that's great. And then the fact that you mentioned to have a chart or a journal is even better, because that can just say, here you go, here's my book, please have a look at it. And I find that has helped in the past for myself, or, advocating for the person that I support. And as I said, it's just having that confidence to go into, the appointment, and just having that conversation, whether you are, changing your diet, and mentioning what may be within your family tree, to say these are what's, and whether or not that will trigger, some other light bulb to go on in their heads, to kind of say, let's have a different viewpoint. So, I mean,
and I think the other thing is to ask your family. I think we're all very guilty of not doing that, but to ask your family, look back into some research as you did, and you found that, I mean, obviously people don't nowadays die of pernicious anemia. And also what was interesting to me, a speaker at a recent Club 12 meeting came along and said that they had done some research in their own GP practice, and they had asked their patients, the number of patients who were on B12 injections, if they knew the reason they were on B12 injections. And a lot of elderly people responded that they didn't know why, because there was generationally a different attitude to doctors. And so if a doctor said to someone maybe of your grandparent or great-grandparent generation, you need B12 injections, they may never have heard the word pernicious anemia. So I think asking around that was, do you know anyone in our family that had pernicious anemia, or were they on B12 injections, or did they have other related conditions like iron deficiency, like thyroid problems? I think once you start putting that out, where the celiacs, as soon as you start asking those questions, and if there is a pattern that comes out, then I think you need to share that with your doctor. Life has changed so much in terms of the healthcare profession. Years ago, the doctor probably saw a whole family or knew your family history. That isn't the case anymore. So the patient has to take responsibility for their family history. And also with the chart, I think not only is it helpful to share that with the healthcare professional, but I think it's also helpful very much for the patient, because what you learn from the chart are the things that the triggers and the flags that make you realize what needs to happen. And often, people have said to me, oh, you need an injection. And I find that really interesting, because for me, one of the first things that happens is my sentence stringing together. So and that comes, I feel a bit tired, I start on not being able to find the right words, and one of my children or my husband will say, I think you need some B12. But then, the next morning I'll wake up and my pins and needles will be slightly worse, and and if I've left it too long, my right eye will twitch, and I'll spend 18 hours asleep, and and I know what all my symptoms are. But I learned a lot of that from a chart that I kept in the early days.
No, you definitely do, because that will then show, certain triggers. And as you said, if there are any type of allergies that you may have, that too can come out. And, and as well, if it was a hot day type of thing, as to why you felt that much more down. And as you said, this is a water soluble vitamin that you will sweat out. So it's all these different things, and to kind of look at things kind of differently. So
and if you're run down, if you have a cold, if you become more active, one of the things that's always very interesting for our members is once they've been diagnosed and they'll get some B12 and they'll start to feel better, and suddenly they'll go and do a lot more. So they'll say, oh, I've been to the gym, or I've been swimming, or I climbed a mountain, and I feel absolutely terrible. I'm like, well, yeah, because you've used up all the B12 that you need to pace yourself and make sure, if you're doing more, then you probably need more B12. And we're all a little bit guilty of that when you do feel well, you go around like a whirlwind and you try to do everything. And I think we all need to sort of practice a little bit of self-care sometimes, and say, actually, what I need to do is to remember I do have a condition that will and especially if you're dealing with other conditions as well, if you have thyroid problems, and obviously thyroid medication needs adjusting every now and again. People if your circumstances change, so a lot of young women, for example, on the contraceptive pill, if that changes, if they come off or if they go on it, that can affect their B12. Certainly if you have a baby, the baby will take more B12. If you're breastfeeding, B12 you will be using more B12.
Yes.
So all of these things you need to bear in mind, and these aren't necessarily things that your GP will think of, or your healthcare, your nurse or whatever will think of, but you need to know that your body, if you cannot absorb B12 through by eating more steak or red meat or whatever, then you're going to have more regular injections. And I think that's always another interesting thing as well, with the sort of intolerance that people have. If I had a $1 for every time somebody said to me, you're anemic, why don't you just eat more meat? That doesn't work. I mean, that's not going to help. But obviously having a healthy diet is important too, because you do need folic acid, you do need magnesium, potassium, you need all these other things, iron, to make sure that your blood cells are being made healthily.
Definitely. And thank you for that, because that's really needed to be heard and to be said. And as we come to a close with this, and end this great discussion, because I could talk for hours about patient care and advocacy, but with your organization, what are the current call to actions, whether it's support or advocacy for individuals with pernicious anemia?
So the things that we're really focusing on at the moment are really about diagnosis and treatment of B12 deficiency and pernicious anemia. In the UK, the body NICE that sort of sets the guidelines for doctors, they are reviewing those, and they will be published hopefully early next year. And we know that other countries will look at those, because the UK is looked at as a sort of comparison for what guidelines are. It's really important that those guidelines are good and accurate, and we've been stakeholders and we've been contributing to that. It's also really important that when they are published, that they get out there and we educate both patients and the healthcare profession about what they say and what is the right thing. So we are working extensively on education packages around that. We're looking at the research areas that I talked about. We're also trying to use more modern media to communicate. One of my big frustrations is the mainstream media who want to narrate a specific story about B12, and they'll quite often get it wrong, sometimes very wrong, and we want to be able to respond to that in a constructive way. So for example, in January, it's very popular for people to cut meat out. You have a focus on plant-based diets and vegans, and there's this dietary B12 deficiency and non-dietary deficiency. They're not exclusive to each other. You can be a vegan and still have pernicious anemia, and so there's no point saying to a vegan, make sure you take enough supplements, because if those supplements and they're still having symptoms, they need to come back and look at whether they have a problem. So there's a lot more information and misinformation that we need to correct. That's something that we really want to work on. We also really want to grow more internationally. There's a lot of countries where there isn't the support there for people. We know from the support groups that we started in the US, and we know Australia is another country that responds to that as well. And we want to look at ways of doing that and providing what people need in different ways, and whether that's newsletters, whether it's help sheets, whether it's online support group discussions, whether it's face-to-face discussions, whether it's one-to-one help. Other things that we do and people often don't realize is we also provide expert witness information. So people, for example, who've been discriminated against because of their condition, they may have lost their job, we can provide information to help people in those circumstances as well. So we are a membership organisation, So that's how we fund the work that we do. It's relatively small amount. Obviously, the amounts on our website are in sterling pounds, but you can pay in your local currency, whichever country you're from. And we really would like our membership to grow in terms of diversity, in terms of age group, and in terms of the female-male ratio, because when we start doing, for example, familial research, it would be great if all those people are available to answer those questions. So that's something, again, that's a mission of mine, is to make sure that we have a very diverse and age wide group of people that we can call upon to contribute to the research, which would make the research more credible and more accurate, obviously.
No, thank you so much. This has been a great discussion, and I'll definitely put those links in the show notes so people can be able to access them and to be able to increase and decide what they want to do. But I really do appreciate this conversation and your time, Katrina, for coming on to the podcast and speaking about this particular condition. Thank you.
Thank you. Thank you.
Hoped you enjoyed this episode, and if you did, please make sure to like, follow, subscribe, and write a review for the episode wherever you listen to your podcasts. Thank you.